right, so this is the first video of the removal of mechanical ventilation and weaning process. So I'm Nick Riesenberg. I'm a recently graduated respiratory therapist, currently working in the medical intensive care unit. I'm taking care of a mechanically ventilated patient today with COVID. His name is Mr. Rudd. His ideal body weight is 50 kilograms. He's lived with chronic obstructive pulmonary disease for the last 10 years, or COPD, as we mostly shortenly hyphenate it. And the attending physician is wanting to start the weaning process, but is also very cautious about the weaning process because of previous hospital admissions. Mr. Rudd was particularly difficult to wean and had to be reinstated on the vent and reintubated and had long stays on the vent. So he's a little bit nervous about facilitating this weaning process. So my role in the successful weaning and removing of the positive pressure ventilation of getting him off the vent would be first assessing that he is able to wean and is ready to wean. And to do that, I'm going to first make sure that he is off sedation and paralytics and that he is awake and coherent and can understand what I'm saying and respond to me. I want to see that there's at least some evidence of a reversal of that respiratory failure, because we didn't put him on a vent because he has COVID or COPD. We put him on a vent because he was going into respiratory failure. And I want to make sure he has an adequate PF ratio of 150 to 200, PEEP less than 5 to 8, for FiO2 less than 50 to 40%. Now, if he's on 50%, I would like his PEEP to be around 5. And if he's on 40%, it's okay for his PEEP to be up to 8. I want to make sure that his heart rate is greater than 50 beats per minute, but less than 130, and his core body temperatures less than 38 degrees Celsius. His pH is above 7.25. His hemoglobin is better than 7.0. He has a cough and gag reflex. He's hemodynamically stable and has the ability to make an inspiratory effort. I also want to check his minute ventilation, make sure it's less than 10 liters a minute. His respiratory rate's less than 30. His tidal volume is over 5 mLs per ideal body weight per kilogram. Vital capacity, which will be part of the pulmonary mechanics, is greater than 10 mLs of his ideal body weight or greater than a liter. His MIP, or negative inspiratory pressure, is greater than -20. His RSBI, or rapid shallow breathing index, is over 100. Or excuse me, less than 100. His SpO2 is greater than 92%, and that he is not showing any more of those signs and symptoms, or at least has progressed in a positive way. So first, I want to make sure that he is in a position to even start this weaning process by doing those assessments. And then once we do that, I want to monitor him during that weaning trial by checking his heart rate, making sure his heart rate isn't increasing by 20 or going down by 20, that his SpO2 isn't dropping by 4%, and make sure he's not showing any signs of increased work of breathing, that he's diaphoretic, he's sweating, I'm seeing retractions, and he's seeming agitated, because now that he's off sedations, if he's seeming agitated, that means he's having to work a little bit hard, and I don't want him to have to work too hard, because that's going to be a problem in the future, because this is just a stair-step process to getting him to where he's breathing on his own. And if he's showing a lot of increased work of breathing or these signs this early on, then it's probably not going to work. I also want to, during that time where we're doing that weaning trial and watching him, be present and coach him and talk him through it. That's another big piece of it, is letting him know that, hey, this is what we're doing in this process. We're turning these rates down. You're having to breathe a little bit more on your own. We're here for you. Just try to remain calm and take big, deep breaths, efficient breaths, and not work too hard. Just keep as calm as possible, because I think that's a big thing that I've seen is it's got to be hard. I can't understand, because I've never been in that situation, but to help keep them less agitated and not worried and anxious, because the ventilator in our bodies is up here, and so is where we feel agitated and stressed. So if we can kind of knock those down and make them feel like, hey, you're not alone in this process. I'm here with you. I'm talking you through it. I want to get you through it. Then that's going to help a lot. Also, this picture in the background, this is my patient, Mr. Rudd, while he's currently on the ventilator. So you can see at this point, he's still sedated, but we're working to get him back to that point. So after the weaning trial, To keep Mr. Rudd from failing an extubation, first off, during the extubation, I want to make sure that I tell him my process, what we're going through, and that I need him to cough and when to do that and to continue to cough. So I'll tell him I'm gonna count down from 3 to 1, and then I'm gonna say cough, 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 and I want you to continue to cough and not swallow, and I'm gonna suction out your airway. And the reason I want to do that is because I don't want him to swallow any of those secretions that could go into his lungs and cause him to have that ventilator-associated pneumonia, or even aspirate, which either one is inevitably probably going to put us right back on the vent. So that's a big point in that process. But after I've extubated him and put him on a nasal cannula, it's just more of that talking to him and making sure he knows he's not alone and that we're here working this with him and that the nurse is going to be involved and we're going to be in here and make sure that he's okay. Just to remain calm and take good, nice breaths, normal breaths as possible. Try not to breathe really quick and shallow, and that we're going to help work him to that point that we can take him off that nasal cannula and that he can go home.